primera conferencia por el doctor Adrian Fung, que viene de Sydney, y nos va a hablar de los hamartomas del epitelio pigmentado de la retina asociadas a la poliposis aderomatosa familiar. Bienvenido, Adrián, y muchas gracias por estar con nosotros.
Buenos dias. Hello, my name is Adrian Fung. I come from Sydney, Australia. I'm very, very excited to be here at ACAREV, and I'd like to thank your president, Juan Arias, Francisco, everybody who's made me feel welcome. I'm very excited to share some of my knowledge here over the next few days and also learn from all of you. It's my first time here in Colombia. I've only been here 24 hours and I've learned two things. Firstly, Colombia is a long, long way from Sydney, Australia. And secondly, you have an absolutely beautiful country. I had the opportunity to walk around the old town yesterday to really feel the history and see all the beautiful buildings, the wonderful people, and enjoy some of your wonderful food. So thank you very much. Can we go to the first slide? If we can go back to the first slide for me. Maybe I'll turn it. Okay, so this is my first talk, and it's on retinal pigment epithelial hamartomas in familial adenomatous polyposis. Here are my financial disclosures. I think most of you would recognize this type of retinal lesion, this dark pigmented fundus lesion with a white fishtail. And you'd be correct in thinking that this is a lesion that's associated with a condition called familial adenomatous polyposis. This is an autosomal dominant condition in which patients develop colorectal polyps and often cancers if they don't have a prophylactic colorectomy. But this condition is also associated with many extracolonic manifestations, changes in the teeth, changes in the skin, such as epidermoid cysts, changes in the bones, such as osteomas, and also other tumours, including desmoid tumours, pancreatic, liver tumours as well. But the one that we're most familiar with as ophthalmologists is this particular lesion, and it's had different names over many, many years. So it started being called pigmented ocular fundus lesions, which isn't particularly a very specific title. It was then called atypical chirpy lesions, multiple RPE hamartomas, and the name that we now currently use and is most commonly used is RPE hamartomas associated with familial adenomatous polyposis. So the objective of this study was to study these RPE hamartomas associated with FAP and to use our current multimodal imaging techniques to understand them more better. This was a prospective observational case study that was performed in multiple clinics in Sydney, Australia. We included all patients that had a genetically diagnosed FAP, or they had a family history of FAP, and they had clinical conditions that were consistent with this, such as a colonoscopy showing polyps. We use multimodal imaging, and particularly ultra-wide field imaging with steering in all gazes, both colour fundus photography as well as fundus autofluorescence, OCT of the lesions and ultra-wide field OCT if required, and also, when possible, OCT angiography. This is an example of the ultra-wide field images that were obtained. So an Optos camera system was used, but it wasn't just performed in the primary gaze because we wanted to really carefully study the whole retina. So we looked also in all patients, asking them to look in up gaze and left gaze, down gaze, and also in right gaze. And this was performed for all patients, both for colour fundus photography and for fundus autofluorescence. You might look at this fundus photo and think that it, on first inspection, looks quite normal. But when you look very carefully, you'll see that there are these tiny little pigmented dots. And so this is why the ultra-wide field imaging was really important, because it was the only way we could accurately document such subtle changes in the fundus. We classified this based on a modification of a prior Torino classification. So these were small pigmented dots, less than 0.2 millimeters in diameter, that could either have or not have depigmentation around it. Smaller areas, less than 0.4 of a millimeter, with or without depigmentation. Larger oval pigmented lesions, greater than 0.4 of a millimeter. Irregularly shaped lesions, or depigmented lesions. So there were these 6 different categories that we classified patients in. This was the fundus autofluorescence that was performed in all gazes. And this is an example of the OCTs that were performed through these lesions so we could accurately document them. We measured the thickness of the choroid as well underneath the lesions, as well as 50 microns outside of the lesion to see whether there were any choroidal changes. Some patients needed Optos ultra-wide field OCT, as this was the only way to accurately document these lesions. And this is an example of OCTA performed over the lesions. So what did we find? So there were 24 patients in total with a mean age of 46 years. 8 of them were female. They were all Caucasian. 2 pairs of patients were related to each other. They had, in general, very good vision of a mean of 20/20 with no symptoms and a normal axial length. I'd like to present 10 key findings from our study. So the first thing is that all of these patients had bilateral involvement. We found 233 lesions in these patients, and surprisingly quite a high number of lesions, almost 10 lesions per eye. The majority of these lesions were temporal, and 89% of them were outside the posterior pole. The second key finding is those little dots, in fact, those small pigment dots are actually the most common manifestation of RP hamartomas in FAP. It's not the large ovoid lesions with fishtail that we're more familiar with, but it's these small pigmented dots that were found in over 40% of patients. Of the lesions in total, they had a base length mean of 0.6 millimeters and a base width mean of 0.2 millimeters. About half of them had surrounding depigmentation, and about half of those with the surrounding depigmentation had the typical fishtail appearance that we ascribe to these lesions. The larger the lesions were, the more likely they were to be posterior, non-circular, and with variable pigmentation. In terms of autofluorescence, the lesions themselves were hypoautofluorescent, almost predominantly, and the depigmented lesion was either isoautofluorescent or hyperautofluorescent. Of the OCTs, we had 48 lesions that could be scanned. 83% of these showed thinning of the outer retina, very similar to what we see in our typical chirpy lesions from the outer nuclear layer out. Retinal pigment epithelial changes were seen in about half of these patients, and about a quarter of these patients had a pigment epithelial defect. Here are some changes. You can see some small PEDs on the left, migrating to intraretinal pigmentation on the right. Some patients showed focal choroidal excavations, which were conforming. Some patients showed subretinal clefts. The choroidal thickness, 50 microns outside the lesion, was not statistically different to the choroidal thickness underneath the lesion. And finally, flow voids were seen in all these lesions on OCT angiography. So this was really the first study that has comprehensively looked at RPE hamartomas and familial adenomatous polyposis using multimodal imaging, such as outlined here. What did we find? We found that all patients had bilateral lesions, that there were an average of 10 lesions per eye, that the most common lesion was in fact very small pigmented dots. They share similarities to our typical chirpy lesions in that they are hypoautofluorescent and they show thinning of the outer retina. But there are some clues and some differences. So firstly, compared to chirpy lesions, these tend to be bilateral and multiple. Half of them have a surrounding depigmentation and half of those have a fishtail lesion. We didn't see lacunae in any of our lesions, and there was no orange pigment, drusen, or cystoid macular edema, and about a quarter of these lesions had pigment epithelial detachments. I'd like to thank my team for this study. Thank you very much.